Welcome once again to the DRH show. Today I'm joined by a lead therapist and addiction counselor at the Cabin. It's one of Asia's most respected rehabs, Lee Hawker-Lecesne. Thanks for joining me.
Oh, you're very welcome. Thank you.
Well, it's great to have you here, Lee. So I understand you used to work in Essex in the late 90s, but you're now based in Thailand. So Tell us what led you to move there, your trajectory in life, and how you ended up doing what you're doing.
I left Essex must be about 12 years ago, and I was actually following family that wanted to move out to. They wanted to go to Mauritius, to be honest with you, and I managed to talk them out of that. Not for any other reason other than it would probably be difficult to find paid employment on Mauritius, it being so small. So I negotiated that we go to Thailand, and there was a job available at a rehab on Koh Samui, which is a small island in the Gulf of Thailand, and I quickly took up that position, but there's a whole story behind that one. But I eventually transferred up to the Cabin Chiang Mai, which is where I've been based for the last decade. I guess going back, I never actually envisaged working in applied psychology or addictions. To be honest with you, I actually wanted to be a pilot and fly fast jets. But life being what life is, I ended up working for a charity about 20 years ago that were really had a health promotion agenda, working with the LGBT community during the height of the HIV pandemic. And so I was doing a lot of behavior change work through this charity, doing harm minimization, which was something I knew very little about at the time. So I was particularly involved in setting up needle exchanges in Essex for injecting drug users, and gradually drifted into this line of work where I had quite close proximity to a lot of the injecting drug users of South Essex. Trying to get them to modify their behavior to curb the transmission rates of HIV. And it kind of grabbed me, really, the one coming from a background of working with the LGBT community with HIV, and then being confronted by the adversity and hardship that most drug users live with. I think drug users, obviously, their behavior is sometimes errant and very antisocial. And they get demonized for what outwardly appears to be very antisocial behavior, but behind the behavior are people that have endured quite a lot of suffering and are stuck in a way of being that none of them welcome. So I actually started to get very interested in how do we change their behavior over the longer term, because obviously harm minimization and needle exchanges deal with very short-term change. But in terms of long-term change, I was puzzled as to how that could happen. So I ended up going back to university and studying what was something aligned more with forensic psychology rather than clinical psychology, because I guess with addiction sits between two disciplines in psychology. Obviously, the reason for that is addiction has historically sat within the criminal justice system. So drug users, people that use drugs, deal drugs, what have you, handed off to the criminal justice system, and they're typically treated within that system very, very poorly and with very poor outcomes. But there's been something of a sea change in terms of treatment approaches to addiction, and there's been a shift away from criminal justice into more medical models of working. And so now what you find is that addicts and people living with addictions tend to be treated as patients rather than criminals or convicts. And so their treatment sits within medical discourses. So addiction can be treated typically by clinical psychologists, but has also been under the remit of forensic psychologists as well. So I ended up studying behavioral sciences, which is has a leaning toward forensics. But in doing that, I was fascinated by this question of how do people move from something that's pretty much got its origins in the, the neurological underpinnings of the brain, addiction, and how do they manage to scratch that itch, that drive that takes them towards using drugs and acts of self-destruction, and overcome that and start to begin to lead meaningful lives in recovery. So I did some postgraduate work studying addictions, and that's really how I sort of gravitated into this field. But as I say, I always wanted to be a pilot, so it's been an interesting journey.
Yeah, so Lee, definitely it has been an interesting journey, experience-wise and also qualification-wise. So I would imagine those things become so instrumental with your role in the cabin. So tell us more about your role in the cabin.
Yeah, so when I first arrived out in Thailand, as I say, I was based down in Koh Samui in a very small clinic. It was only about 8 beds, and it was perched on top of a hillside overlooking an archipelago that was quite striking in appearance. But in terms of the way that the company was set up, they hadn't really kind of got the basics in place in terms of clinical efficacy and standards. And so I was a bit concerned with the practice there, and that's remained with me to this day, because the trouble with addiction treatment, and you see this in the US as well as in other countries, is that it's historically been quite easy to open up a treatment center. Obviously, there are some countries where it's very heavily regulated, so Europe and some of the US states, Australia, what have you, but there are also some very shady organizations, and obviously, when you're dealing with people that are extremely vulnerable and facing a time of crisis, they can become exploited by some of these shadowy operations. So when I first landed in Thailand, I felt like I was not seeing the best of what treatment could offer, having come from the UK. And I had initially contacted the cabin because they caught my eye because of the strength of their clinical program. I'd seen it from the UK. So I'd kind of engaged with them, but they didn't have any vacancies for psychologists at the time that I moved out here. But fortunately, I think within a year of my landing in Thailand, a vacancy became available at the cabin, and I transitioned up there. And personally, it felt like a breath of fresh air to actually be somewhere that was, one, extremely dynamic, because they were pretty much breaking the mold in terms of what they were offering treatment-wise. But two, somewhere that was also, I don't know, there was something electrifying about the atmosphere at the cabin. It was a very dynamic environment, the way that they delivered treatment. So, I was completely enamored by it. And I joined them initially in the role of psychologist. There was one psychologist on the team and 5 counsellors. And as it was back then, so the counsellors used to tend to do a lot of the heavy lifting in terms of the counselling work and the group delivery, and the psychologists tended to get some of the more complex cases, should we say, the cases that presented for treatment with dual diagnosis and that required additional assessment. So I joined the clinical team at the cabin. Bit of a binary role, as I say. I got taken on as psychologist, but I was in with the counsellors doing a lot of the groups and carrying caseloads. But I think because I had that additional bit of training, or that perspective of coming from a field of psychology rather than pure counselling, I was typically given most of the assessments, the pre-admission assessments, to do the gatekeeping, because I think one of the things that I've noticed, and maybe we can come back to this, is with some of the bad actors in this field, there's a distinct lack of gatekeeping and clinical assessment. So there are treatment centres out there that have a very catch-all approach to admissions, whereas I think realistically, if you abide by any ethical framework or code of good conduct, you'll only treat those clients that you're competent to treat, and that involves, difficult conversations as to whether you're the right provider. So I was given that remit at the cabin to ensure that the standards of gatekeeping and assessment were maintained, and that really does sit within the field of a psychologist. So I spent the bulk of my time at the cabin doing that, and then there was a phase where the cabin the cabin did expand very quickly. It got quite a good reputation overseas and internationally, and we were seeing quite a spurious increase in clients. And the gatekeeping role that I had went into overdrive, and I suggested that we open up something called a behavioural science unit, which is really about looking at differential diagnostics, because I guess most people think of addicts as being people that, you know, have an overwhelming compulsion or obsessive, you know, thinking pattern around drugs or addictive behaviors. But what you tend to find is that there's a very high rate of comorbidity and co-occurring disorders with addiction. Most lately, it's been because of better screening approaches. It's been found that you know, a lot of addicts have experienced a lot of trauma in their lives, and that, you know, the environmental triggers that can trigger an addiction have their origins in complex and sometimes acute trauma. So the differential diagnostic unit that I set up was really involved in looking at what's behind the addiction, because it's one thing to label someone with a disorder, but if you miss the boat in tackling the underlying problems, that, you know, that problem is likely to resurface either in its original form or in a different form. So I spent about 3 years running a behavioural science unit, which was, as I say, looking at differential diagnostics. And then I think in about 2018, the opportunity arose to step into an acting chief clinical officer's position at the cabin when they were transitioning away from their current head of clinical services. So I stepped into that. And that's where I've been for the last the last few years. I tend to have stepped away from some of the clinical duties and involved in the oversight and strategic development of the cabin today.
Mm-hmm. Now, Lee, let's touch more upon, because you alluded to the different frameworks where some treatment centers operate. You mentioned that there's some, you know, catch-all approach. And I understand that the cabin offers a more bespoke treatment for clients. So why do you think this is important as opposed to just having sort of generic approach in treatment centers?
Yeah, I think, I mean, there's a number of factors here, and I guess first and foremost, I just want to, you know, touch on that word bespoke, because there are treatment centers that offer bespoke treatment, and what they typically see is individual clients on a one-on-one basis, and they charge an awful lot of money for clients to just be looked after around the clock, and so that's one definition of the term bespoke when you're talking about addiction treatment. There are also those maybe higher end private treatment facilities that see very few clients that use the word bespoke, and then you drop down through the levels of care to those candidates or treatment centers that will see anyone. I guess what we tend to do is, being a private treatment center, we do offer a different level of care than you might find in some of the statutory sector organisations, because they're obviously beholden on government funding, or they have charity status, so they don't always have the spending power of some of the private rehabs. But what we typically do at the cabin is, you know, Thailand is not an expensive place to build to base a business, so those cuts in overheads get passed on to clients, and the treatment prices in Thailand are probably comparable, if not cheaper, than many US or definitely UK treatment centers. But I guess when you use that word bespoke in the context of the cabin, the way that I see that is that we're actually far more rigorous around our gatekeeping. And some of that comes down to public confidence, and some of it comes down to an almost very concrete way of maintaining clinical integrity. Because one of the things I've learned is that with the catch-all model, is that everyone's labelled with the same disorder, e.g. addiction, and everybody is lumped into a treatment program as a homogenous group. And there's no wiggle room in that. Everybody moves through, you know, the program as one cohort. It's very conveyor belt like, and people are often taken into some of these treatment centres with surface level behavior that looks like substance use and may be characterized as substance use, but it's actually another problem, and the substance use is a symptom of the other problem. So I give you an example. People maybe that are living with a diagnosis of bipolar during phases of hypermania or extreme mania act in ways that, you know, to the untrained eye could look like they're spending an awful lot of money, could get labeled as shopping addiction. Maybe they drink excessively, could look like alcohol dependence, or maybe they do a combination of both. And when they present to a clinician or an unwary assessor, what they see is the behavior rather than the underlying problem. So I think it's really important to, from a starting point, to know what the problem is that you're looking at treating, rather than just saying, oh, we can treat that thing there, and lumping everyone together, which is something that happens. So so at the cabin, when we talk about bespoke, is we take an extra level of attention is paid to the assessment process. And if someone's not suitable for the program that we deliver, we will tell them. Okay, it's as simple as that, because I think the problem that you have if you just bring everyone in is, one, you raise the expectations of the client that you can deliver a solution. Two, the family, who are often the unseen victims in the chaos of an addiction, have their hopes dashed. And also the reputation of the sector, the industry, whatever, whichever term you want to use, but healthcare and psychological well-being treatment is tarnished forever because people have been led astray or promised something that's not delivered. So I think in order to maintain public confidence and to actually do people the service that they require, it's better to have a level playing field out front and be completely transparent. So I think we probably turn more people away than we admit, based on the fact that if we're not the right treatment center for them, then we'll let them know. And obviously we don't just give them a hard stop at the point of yes, you can come in, or no, you can't. We obviously signpost people to more appropriate providers, but we wouldn't take someone in on the basis that they've got their checkbook out and they're looking for treatment and they're vulnerable. So.
Absolutely. And of course, Lee, in your treatment center, you help people with a number of mental health issues. But from my understanding, you predominantly focus on people with addiction. So let's focus on that particular demographic. So could you just give us an overview about the addiction, what causes addiction, and how do you differentiate it between someone who's socially active around alcohol, drugs, and other forms of addiction? I suppose I'm quite alluding to dual diagnosis.
Yeah, so with addiction is quite a complex problem to diagnose. And I think you need to differentiate between dependence, abuse, and addiction. Now, addiction is as I say, it's a very pejorative term. It comes with a lot of stigma. For a long time, the word addict or addiction was only ever viewed with a negative connotation. For someone to be diagnosed with an addiction, there are different criteria than there are for dependence. Now, there's a scoring system within the DSM, which is the statistical manual of the psychiatry that's used for making diagnostics. With abuse, drug abuse or alcohol abuse, substance abuse, people tend to use the substance in a way that it's not designed for, or if it's an illicit drug, maybe they use it a level that it exists in the world. Beyond that level, they use too much of it, but they can stop. They abuse what the thing is there for. So prescribe medication, but when things get difficult for them, they can typically stop. The way that I look at the dependence issue is that some drugs come with a physical withdrawal syndrome. So you can take a drug for a certain amount of time and maybe you don't get any significant symptoms of withdrawal when you stop taking it. But once those withdrawal symptoms manifest, you can suggest that there's a level of dependence there, because then you need the drug or a replacement of the drug to be administered in a tapering regimen to get you off of it so that the symptoms disappear. With an addiction, people don't tend to have that choice in the first two. You know, when things get problematic, they just stop. Yeah, they say, oh no, I've made a mistake, you know, this is a bit difficult for me, there's repercussions, I'll stop. Addicts don't have that luxury. And I think the thing that sets people apart with an addiction is two key criteria, and one of those is craving. And we should qualify what craving is really, because people use the word craving very flippantly. You know, sometimes you might hear someone say, oh, I'm craving some chocolate, or I want something sweet. That's not the type of craving that drug addicts or alcoholics experience. You know, craving's an intense, obsessive ritual that results in a compulsion to find the thing that they want to use, and then at all costs seek it out and take it, irrespective of the context of what their situation is. So we really need to understand what the craving is very different in terms of addiction parlance to what it is in everyday use. And then the other criteria that sets addicts or people with an addiction apart from those that are just dependent or abusing a drug is the fact that addicts will continue to use even when negative consequences accumulate, and every ounce of logic is saying stop doing this. Don't do this anymore because the consequences are unbearable. So you'll find that, people living with an addiction will carry on using even as their wife is packing the bags and putting the kids in the car to leave, or, on their way to a court case where maybe it's a 3 strikes and out hearing, and they'll think it makes sense to maybe go into the court case having, used something immediately before. And I think that's what sets addiction apart, is this persistent use despite the accumulation of negative consequences and the physiological and psychological and distress caused by craving. So with addiction, there's been this misunderstanding, and it's a misconception that's existed for some decades now, that addiction can be, it can be treated in quite a short period of time, and then people go to AA or NA meetings afterwards and everything's very hunky-dory, and the set period of treatment for a long time was a benchmark that was set by the insurance companies, because they were only willing to pay for a certain amount of time for addiction treatment, and that figure got set at 28 days. And I think for a lot of people it's created an unrealistic expectation that you go to rehab for 28 days, then you go to AA, and then everything's fine, you're cured. And that's not the way it works. By the time somebody gets to a point in their life where they require intensive inpatient treatment, there's a lot that's gone on, and the lot that's gone on takes quite a while to, one, unpick, and two, work through the consequences of. And sometimes we're talking about the breakdown of relationships, we're talking about trauma, just the adversity of living a lifestyle as an addict or an alcoholic is quite shaming, stigmatizing, quite traumatizing. So all of these things have to be unpicked, and treatment typically takes a lot longer than 28 days. So I think what we've tried to do at the cabin is once we've screened someone accurately and intelligently, and we've communicated to them via the assessment process what we think the problem is, we try and be realistic with them as to, look, this is how treatment should play out. And I think for me, one of the main achievements of the cabin was that we have some very good resources at our disposal, in that we have an inpatient facility in Chiang Mai, but then we have an online service, which is an outpatient service that's connected to that. So people can come into the inpatient service and do the bulk of the heavy lifting in terms of stopping their using, getting some medical care in terms of detox, and starting to work through some of the sticky issues that have reinforced the addiction. But then when they leave, we don't just let them go and send them off to a community support group. They're actually held by the outpatient service. So there's almost a seamless continuity of care, which I think is really important. And wrapped around that we tend to work quite heavily with the families. So we have a lot of family programs where families can actually get some support, because obviously when people come into treatment, all of the focus is on them, but the people that they've been living with, that they've been potentially abusing the trust of, there's been a huge amount of betrayal within the family. And sometimes the family can serve as enablers. People living with an addiction are very good at shaping their environment to be able to, achieve the end goal, which is to use. And if that means manipulating or molding people into a way of being that facilitates that, then I think those people need to be worked with as well, because otherwise when the client comes out of treatment, they go back into a relationship that's been based on exploitation and potentially abuse. And there's a lot of unresolved anger and issues there. So we work with the families as well to try and resolve those issues.
Yeah. So Lee, as you've said, these families are often in the periphery of the treatment process. So what would be your advice for anyone who may suspect a loved one needs help?
I think what's really important is living with someone who's in an addiction. It's an absolute minefield, because you don't know what's real and what's not real. You've got two competing agendas here. You've got the person with the addiction, who for good or for bad, to all intents and purposes, has one goal, and that goal is to scratch that itch and to use. And sometimes there's an awful lot of gaslighting and lying that goes on within families, just to be able to get through the next 15 minutes and inch closer towards that, achieving that goal of using. Now the trouble with that is it comes at a cost. And I think the families often don't know what's up and what's down by the time the client's ready to go into treatment. So I think the primary recommendation I would say is to reach out and speak to someone. Ask for help. Don't try and do this on your own, because it's a very, very complicated lifestyle, working with and living with addicts and alcoholics. They're very adept at creating a reality that serves them. And I think, part of that is about, there's a certain amount of mind games that get played. And so I would say, in order to get some objective support, speak to someone, reach out. And to all intents and purposes, it doesn't have to be a treatment center that you're planning on sending a client to. I think sometimes if you just reach out, whether it's to an outpatient practitioner or a therapist or a treatment center, and there are some good treatment centers out there. So I think that's a starting point, but don't try and fathom this out on your own, because I think, one, it's a very lonely existence, and two, you're up against it, because you're dealing with a scenario where the person that you're trying to get help for is sometimes oppositional to the idea of help, and sometimes is antagonistic to you even reaching out for help, because it could signal the end of the addiction. So I would say reaching out for help is the main thing that I would suggest. And I think, even if, and this is a very difficult one, because this comes down to boundaries, and boundaries are very difficult to maintain when you're dealing with such a slippery disorder like addiction. I think for the families or the loved one to get some help themselves, and that doesn't always make sense, because they think, well, he's got the problem, or the problem sits with her, it's up to them. But I think actually this problem exists within a relationship with the families a lot of the time. As I say, addiction doesn't happen overnight, and the living arrangements that support an addiction playing out have obviously taken time to evolve, and sometimes they've been manipulated to work out in one party's favor rather than the other. So I think it's really important for the families to get help and support, because even if they're able to reach out and get some support themselves, I think they can go into the conversation of what the addict or alcoholic needs, being able to hold some more robust boundaries, rather than just getting buffeted around by the gaslighting or a lot of the half-truths and deception that goes on within an addiction.
Lee, let's pivot the conversation back to you doing a PhD, because you already have sufficient practical experience and you have expertise. You're quite knowledgeable about what you're doing. So,
Yeah.
what do you think? You need to do a PhD, and haven't you been deterred because there's a lot of time, effort, and financial investments, and also, I would imagine you're doing your PhD not in Thailand. So,
Yeah.
and also, I understand that you've published a number of papers. Why do you think this is important to kind of carry on doing your qualifications?
I think I mean the first part of that question. I've actually, since we relaunched the cabin, because COVID, quite frankly, decimated the whole sector. For those rehabilitation centres that are relying on overseas travellers, when a lot of the countries closed down their borders, it basically just asphyxiated the supply of clients coming into the treatment centres. So everything became very dormant, and so we've had to relaunch the cabin almost from day one. And although they're a well-respected brand, it's taken up a huge amount of my time. So in terms of the PhD, I've had to currently put that on hold because I'm just kept. I mean, PhDs are a very lonely. they're a very lonely passion because obviously there's so much time required to actually kind of immerse yourself in the work that you're doing, the research. But what I've done since we've relaunched is try to keep my own, I guess my own academic blade sharp by making sure that we disseminate a lot of information and that we focus on generating data and information that's useful for the sector. So whilst a lot of that isn't about empirical studies or large cohorts of clients that we're studying and publishing research papers on in the academic literature, we're very, very busy actually, I guess, reporting on best practice. And what we're currently trying to do is engage more of a service user involvement angle, because all too often treatment centres and the staff that work there sit within a very unhealthy power dynamic where they're seen as the experts and the client is the patient, and it's all very sort of subject driven. But what we've tried to do at the moment is to break away from that model and actually start to engage clients in saying what's your view on treatment, what's worked for you, what would you like to see more of, what would you like to see less of. And I think that's a trend that for me I'm quite interested in developing, because you don't tend to see service user involvement within the private sector. It tends to be something that's sits within the dominion of statutory sectors where strategic leads and bodies, commissioners of drug services at the strategic level, often seek out the guidance of service user representatives. And at the moment, we're actually trying to involve clients more in saying, look, this is what the model of best practice suggests, but what's it really like at the coalface in terms of you accessing treatment?
Absolutely. Well, thank you, Lee. We're already approaching towards the end of this interview. You told us about the cabin and the treatment services that you're offering, and also you gave us an overview of the addiction and how important the support system is. But let's wrap this up with some light-hearted, quick-fire questions. So I saved 3 simple questions for you, just to we can get to know you more of as a person rather than as an addiction counselor. So first one, Lee, what were you afraid of as a child?
Oh gosh, what was I afraid of as a child? Heights. I would say heights. Yeah.
Mm-hmm. And what is your favorite word in another language?
Hawker, French. Heart.
Which?
Yeah.
Heart. Okay. I thought you're gonna say cup and cup. If you weren't working in the cabin, what would you have pursued in your life? Pilot. You already mentioned that. But if not being a pilot, not working in the cabin, what would it have been?
I would have had an absolutely stunning career as a fast jet fighter in the Royal Air Force, and I'd currently be captaining an A380 Dreamliner with Emirates Airlines at the moment. There you go.
Okay. And finally, Lee, the floor is all yours. What should people take away from today's conversation? What's next for you?
I think if you're looking for treatment, then do due diligence. Speak to a number of treatment centres. Get some objective feedback. Don't just turn up in a state of desperation at the first place that offers you a bed, and take that, because I think you only want to do treatment once, and you want to do it well, because it can be costly and not just financially. I think there are some very good treatment centres out there. I think people can always, even if they just want an opinion, they can call us, because we don't chase volume. We have a limited number of beds, and we're quite choosy as to who and what we treat. So we're always welcome to speak to people and offer candid advice on what they should do next, or what the next steps are if they need help.
Absolutely. Well, Lee Hawker-Lecesne, lead therapist and addiction counselor at the Cabin. It's great to have you here on the DRH show. And for anyone who's watching, all the links will be in the description. Thank you.
Thanks awfully. Cheerio.